Dawn Cooper, Senior Health Economist from Cook Medical, and I've recently collaborated with Ben Norton, Andre Talise and Rehan Haidri from the Cleveland Clinic, Shrisha Hebar from Royal Stoke University Hospital, Neil Hawkes from the Royal Glamorgan Hospital, John Morris from Glasgow Royal Infirmary and Alan Barkin from McGill University. And I'd like to take this opportunity to talk about our recent paper titled TC-325, Hemostatic Powder as First-Line Treatment for Malignant Gastrointestinal Bleeding, a cost-utility analysis in the United Kingdom. Malignant bleeds are challenging to treat with standard endoscopic therapy. The bleeds are often diffuse and the tissue is fragile. Results from standard therapy can be highly variable. TC-325 is a topic hemostatic powder known to be simple to use and effective on complex, challenging bleeds. Recent multi-centre randomized control studies in malignant bleeds have shown significantly higher immediate hemostasis and lower 30-day rebleeding rates for TC-325 compared with standard therapy, indicating that TC-325 is a clinically effective treatment option for malignant bleeds. However, something which may impede the use of TC-325 as a first-line option is the initial purchase costs compared to standard care. So with this in mind, we sought to explore the clinical and cost effectiveness of TC-325 compared with standard care as a first-line therapy for malignant GI bleeds. To do this, we created a decision tree from the UK NHS perspective, looking at the costs and consequences over a 30-day time period. In brief, in this model, any failure to achieve immediate hemostasis or rebleed results in further intervention. Mostly this would be endoscopic therapy, or in some cases it can be escalation to embolization or even surgery. Additional treatments incurred additional costs and also increased the length of stay for the patient. And as with other bleed models, it was assumed that the quality of life of the patient was lower when they were in hospital compared to being at home. We used pooled data from 3 randomized controlled trials which compared TC-325 with standard care in malignant bleeds to ensure the model was as generalizable as possible. We also include multiple scenario analysis, one of which focused on using the data from the largest randomized control study, which was in non-palliative patients. The base case data indicated that TC-325 would be cost saving to a tune of around about £250, and there was a small gain in quality adjusted life years, or the QALY. Probabilistic analysis indicated that TC-325 had an 80% probability of being cost saving. All of the different scenarios continue to report that TC-325 would be cost saving and there was a QALY gain, although the magnitude changed slightly. There's a lot of variability in managing patients with malignant bleeds, and no single study was able to source the data to create this model, so the model does remain pragmatic. So in future, it'd be great if randomized control trials would better report on the quality of life parameters and detail the treatments post-rebleed, so more precise models can be created. So to conclude, given the increasing body of evidence supporting the clinical efficacy, and now we have the cost effectiveness data for TC-325, it really would be prudent to consider this hemostatic powder as a first-line treatment for managing malignant GI bleeds.